Hi, everyone. Welcome to another masterclass webinar series, but this time we're doing an IDCP info session. But anytime we do this, we always try to make it very practical for all of you that are also, thinking about how do I incorporate this into the clinic, or how do I make this so that it's practical when I'm thinking about patient care, or maybe even the more important thing, how do I extend what I already have learned into new areas where I can adopt new tools so that I have more tools in my toolbox. So let me start by saying welcome to all of you for joining us here. And today we are going to be talking about hormonal health. And in particular, we're going to be discussing Dutch testing, which is so widely used, but probably not widely just understood in the ways that we could really maximize its impact. And so we're going to take a case-based approach for managing acne in women. And I am very, very excited that I am joined by Dr. Rubina Dang. She is a naturopathic doctor. I've known her for many years, and she is a very astute clinician, and she's very good about using these in a very practical sense. So let me turn it over to you, Ruby, and you can just give us a little intro about yourself as well.
Thank you, Dr. Simani. That was such a great introduction. But hi, everybody. My name is Dr. Dang, and I'm a naturopathic doctor. And so I've primarily been specializing in a variety of different dermatological conditions. And as naturopathic doctors, what we do is we really try to focus on getting to the root cause of a lot of them. So over many years, I've gotten really, knowledgeable about trying to understand acne and the pathogenesis of acne. And so I'm excited to talk more about Dutch testing because it's one of the most common testing options that I use to try to understand and get to the root of a lot of different hormonal acne in women. But other things that I do is I focus a lot on the gut microbiome. I also work at the Integrative Research Institute, where we are advancing a lot of research in the world of integrative medicine. So there's a lot of new exciting things on the horizon that's coming up.
Yeah, fantastic. And so dermatology is never just dermatology at first blush. It goes a lot deeper than that. So some things that we want to just hope that you take away is identifying what are the key hormones that are involved. We know all the basic hormones, but how do you look at this advanced testing methodology and then glean something out of here that might be useful? And on top of it, what could be, in integrative medicine, it's so easy to say every patient is unique, which is true. They are. But we also need some guidelines on how do you approach this. And so we're hoping to put a little bit more, as we say, salt into the soup rather than just saying the soup can be made by anyone. I made that up, and if it was not a good analogy, that's just my fault. Okay, so then we're going to review the principles, the methodology of Dutch testing, and we'll look at some real actual results. So then that brings us to the next question. Ruby, what is hormone testing? And, there's got to be several that are out there. Obviously, we're talking about Dutch, but maybe you can give us a little overview on this.
So I'll just kind of break down, hormone testing. So usually when people talk about their hormones, they go to their doctor, they're like, hey, something's off with my hormones and I want to get them tested. And generally it starts with blood testing, so serum labs for looking at hormones. So that's one way to evaluate hormones, but it usually tells us how much of the hormone is bound, in the body, in the blood. But there are other ways to look at hormones. So we can now look at hormones through urine and newly through saliva too. So I know today we're going to be talking more about urine hormone testing. And the reason that there's so many different options out there is because urine and saliva can now tell us more about how hormones are bioavailable, as well as their metabolites. So it'll tell us, more of the active forms that are circulating in the body, the metabolites, the byproducts of, certain hormones. So we can now, break down estrogen. We can now look at progesterone and its metabolites, as well as androgens and their metabolites too, as well as see how do they all play a role with one another. So hormone testing is more than just looking through, through actual just lab markers through your blood. We can look at it in a variety of different ways. And what I think is unique about what we're going to be talking about today is we're going to be looking at real examples of patients who've had their hormones tested via blood and what those values are. And then we look at them through urine and we'll be seeing what those values come out to be too.
Fantastic. Well, there are several testing houses, right, for hormones. It's not just one of them. Maybe we can kick it off by just saying what is so interesting about Dutch testing for you, or that matter. I mean, there are multiple testing labs. How do you choose which one to go with, or why did you choose Dutch?
So for me, I look at, obviously what's reliable, what's reproducible. I look at, how do they actually evaluate and interpret their testing? How do they go ahead and, look at the metabolites too? So for me, Dutch is the gold standard when it comes to urine and salivary testing at the moment. There are plenty of other companies out there that are starting to, advance their testing options. I know we've talked about ZRT labs historically in the past. There's so many ones coming onto the market, but I would say Dutch to me has really advanced the field, and their methods of collection and interpretation are very helpful for clinicians as well as patients. So it's really unique about the Dutch test is when the report comes out, there's a way to interpret it that is great for a patient. So they can read it. So let's say the doctor comes back and tells them their findings and that it went completely over their head. The rest of the report's there so they can understand what's happening in their testing as well.
Okay, awesome. So now we've figured out what test we're going to use. So give us this, we've got this plate of, we'll jump into this actually. We've got these plate of hormones that we're thinking about. A lot of us think about androgens, and when we think about androgens, we think of DHT, testosterone. But then don't forget there are many different subsets when it comes to other areas too, estrogen, progesterone. And then we don't want to forget about the impact of cortisol, because anytime we're thinking about any of these conditions, we're always putting this nebulous box of stress. Well, now it doesn't have to be so nebulous. You actually have ways to think about this and measure it and perhaps then address it. So let's jump into the first case, and pretty classic case, 26-year-old female, cystic acne. She's got an irregular menstrual cycle and hirsutism, hair widening at part line. I mean, we've already got the hallmarks of what we're thinking. Okay, it's not just your garden variety acne here. We've got something else going on that may be deeper, and perhaps it's polycystic ovarian syndrome, or at least you're suspectful of that with the irregular menstrual cycles, hirsutism, and the alopecia that's starting to develop. So why don't you take us through how you approach this case, Ruby? Because this is your case, so it'll be really nice to have you walk us through your evaluation and then what you did after you drew the first serum labs and whatnot.
Yeah, gladly. So a lot of times when patients walk in, they're walking in with a constellation of symptoms too. It's more than just these symptoms of acne, irregular menstrual cycles. We talk about their diet. They generally haven't had their lab work done in over a year or a couple years. So the first place that I tend to start with is with serum testing. A lot of times serum labs can get covered by insurance. So a lot of people initially want to go that route. So here's an example of a lot of different hormones that we initially tested on day 19. And the reason that I did day 19 of her cycle specifically is she had a shorter menstrual cycle, meaning her menses were coming every 24, 25 days, yet they were irregular. Sometimes they were 21, sometimes they're a little bit later, but on average about 24, 25. And she did have, I believe it was like an Aura ring. And so she was able to see when her, body was ovulating and her temp was spiking. So we're able to get a little bit of an understanding of, when to collect, because we want to get it about a week post ovulation. So initially, went through her hormones. We looked at so my initial, thought was, it sounds like she has some elevated androgens and PCOS, just like Dr. Sivamani said. So I wanted to see, can any of her labs support that? So we look at her, free and total testosterone and her DHT, which pretty much resulted within normal range. Another thing that I mentioned and like to look at is look at how big the range is too. DHT 9.3 when the range is 4 to 22 is pretty significant. And so, it's hard to tell if she's normal, is she functionally normal, is she ideally normal, like where she's at in that range. But a marker that I wanted to point out is that, her LH in comparison to her FSH. And so with her LH being about 12.6, which is more than double the amount of the FSH, I'd say that's a good clinical finding that is suggestive more of PCOS too. So that was something that, stood out to me from her labs. And then her cortisol generally tend to be with the normal range. So this was collected between 8 to 10 a.m. So morning cortisol looks healthy. Her estradiol, that range is so large, it's hard to know exactly where her estradiol is. And then her progesterone, we can see there looks pretty low. So, 0.3. And another thing that I find through serum labs or even through urine hormone testing too, is there oftentimes can be an inverse relationship between testosterone and or DHT and progesterone in the cases with PCOS. So that's what I found initially. And then she was more open to understanding her hormones a little bit more after these initial labs came in.
And before we go on, I just want to make a comment. First of all, that's an awesome overview and just goes to show that even if you suspect it, the labs can generally be normal. And this is where that clinical acumen of looking for certain ratios or other things, it's so helpful. So it's really nice that you're walking us through that. If any of you have any questions, please don't be shy. You can go ahead and put them into the Q&A or the chat, and we'll try to monitor that. I might not be able to catch them right when you put them in, but we'll try to get to them, as we go along, rather than holding all of the questions to the end. It's kind of nice so that we have a bit more of a moving dialogue as we go along. Okay, so here is the first report. So let's have you walk through it, and then we can comment on it, of course.
Sure. So let's start on the right-hand side here. So usually when the Dutch report comes back, it comes back in multiple pages. Usually it starts with understanding kind of a hormone summary, and then it'll break down the hormones as well as our metabolites. And so this page here looks specifically at her hormones, and what's unique is how they all relate to one another. So we kind of go from the start here. So we look at pregnenolone, and pregnenolone will kind of bifurcate off into two different directions, into progesterone and DHEA. So let's start with, understanding her androgens, because we're already suspecting a higher androgen picture here. So it goes to DHEA, and then we look at her DHEA sulfate, to the right, it's looking in a healthy normal range here. But what's unique is if we look at her testosterone is quite low. So a lot of people, and many providers might look just at testosterone and be like, you know what, that testosterone's low, there's nothing wrong with her androgens there. But that's why it's unique and important to go one step further. So if you kind of go back underneath DHEA into the androstenedione, and then how it bifurcates into 5-alpha, 5-beta, as we now see it visualized on the left. So that is DHT. And so we have the 5-alpha reductase pathway here. And so we can have two isoenzymes of DHT as well. So it can go into isoenzyme 1 and 2. What's unique is that 5-alpha, so that one kind of going towards the right to the androsterone, is the more androgenic. So what we can see here is that 5-alpha and 5-beta right there are quite significantly elevated. Another thing to keep in mind with the Dutch hormone testing is, if you guys can see, the reference values between the two stars are considered normal, and anything that's below that first star is considered low, and anything that's beyond the second star is considered high. So it gives us a range here too. So for this patient specifically, we see that she's favoring the 5-alpha, so the more androgenic form of DHT, and she's producing quite a significant amount of it as well. So even though she has low testosterone, it's safer to say that she has higher amounts of DHT. And what DHT, as we know, is it can lead to a variety of different, constellation of symptoms. It can lead to hair thinning, so it can lead to the, also more of a oily scalp, increased sebaceous glands. It can lead to cystic acne. It can be a contributing factor to cysts on ovaries as well. It can lead to irregular menstrual cycles. So what was unique, was just seeing this difference between the testosterone and the DHT here. And then moving on to the progesterone. So we go back up to the pregnenolone, and we go, to progesterone there. And we see her progesterone is, lower than what we'd like it to be. And there's a nice little purple box there, and that usually says postmenopausal range. So for her, being in her mid-20s, she is trending towards a postmenopausal amount of progesterone. And like I mentioned, I often tend to see an inverse relationship between, DHT and progesterone. So her body is favoring more of the androgenic pathway, and it's not favoring progesterone as much, also contributing to her more irregular menstrual cycles. What's unique about the testing is progesterone then also splits off into two different metabolites as well. So there's also 5-alpha and 5-beta there too. And, generally we can see, do they favor one over the other as well here too. For her, she's underproducing both, but favoring the 5-alpha pathway just slightly more. And then we'll kind of dip down into her estrogens pathway here. So we can see how testosterone uses, aromatase to get into estradiol here. And so then estradiol, it'll tell us about E1, E2, as well as E3 for the patient. But what I look at when it comes to more, when a lot of people say they have more estrogen dominance and they have higher amounts of estrogen, I really look at the estrogen metabolites. So we look at the different pathways of the 16-OHE1, the 4-OHE1, and the 2-OHE1. So we look at her estrogen, her estradiol, primarily E2. It looks, in a good, healthy range. But what I like to look at is her percentages. So if you look at that little pie down at the bottom there, it'll tell you the percentages of where the patient's at, and it tells you the expected of where is more of an optimal range. So for this patient specifically, her 2OH is looking, and 2OH is the good estrogen. That's the one that's protects our heart, protects our bones. That's looking like it's in more of a healthier range for the amount of estrogen that she's producing. Her 4-OHE1 is within that range as well, that 7.5 to 11. She's producing that 9.9%. And then that 16-OHE1, she is a bit higher at 22% on that one. And so a lot of women have normal estrogen, but they have more estrogen-like symptoms, such as breast tenderness, mood changes, migraines right before their cycle. And oftentimes increases in that 4-OHE1 and that 16-OHE1 can be, contributing factors. What I think is going to be unique is we're going to kind of dive more into the estrogen part in a little bit. So I'll save some of the conversation around that, but I just wanted to tie into how all of our hormones relate to one another too.
Well, we already have a question that came in. It says, could you share functional ranges for some of those serum hormone markers? The LH-FSH ratio was really helpful. Any other clinical pearls when looking at serum?
Well, I would say, as we saw with that serum lab, her DHT free and total were considered normal. So that's telling me that the DHT that's bound is considered normal. And so what's more bioavailable is what is coming back as being more abnormal. So when it comes to DHT and testosterone testing, personally, when I look at serum labs, I don't always have a functional range to look at. I definitely look at the ratios of the LH to the FSH because those are just more indicative of what might be going on. But when it comes to the actual androgens, I generally will, favor looking at, hormone testing to get a better understanding.
Perfect. All right. So how did you put it all together and think about a treatment plan? Because that's, of course, the ultimate goal here.
Right. So this is a patient I'm going to start off with. She was someone that was very health conscious. She was someone that was a go-getter. She was very passionate about her health already doing the foundation. She was eating clean, she was exercising, she was eating all organic, eating a variety of different plants and protein into her diet. So nutrition-wise, I didn't feel like that was a huge integral part of her plan that I had to focus on because she was already doing so well. But what I did add in was 2 tablespoons of ground pumpkin seeds daily. And the reason I did that is ground pumpkin seeds help to reduce the DHT pathway. So they help to reduce, the 5-alpha reductase pathway. So I especially recommend ground seeds when including them in plans because you want those essential oils that come out of a lot of seeds, and those are what are helpful. Another hack is you can pre-ground them. So you can buy the pumpkin seeds in bulk and you can ground them, but freeze them right away, and that will preserve the oils too. And then consuming spearmint tea daily also helps to reduce the 5-alpha reductase pathway as well. So I encouraged her. She was a tea drinker. So I said, try to implement it into your routine. You can have multiple cups if you'd like. But then I added in some supplements for her. And so she was actually someone that came in, did her research, was on a whole host of supplements. So I said, less is more in this situation. Let's go ahead and just focus on reducing her androgen, specifically the DHT pathway. And so saw palmetto is one of, the best, and most researched herbs out there and botanicals that can help with reducing the DHT hormone. So usually, the research dosage starts at 320 milligrams. She was someone that was sensitive to some supplements. So I generally always ask patients, do you tend to be more sensitive or how are you with supplements? Or some people are just nervous to start supplements as well. So for her, initially I started her on 320 milligrams, but because her, DHT was quite elevated, we did bump up to 640 after about a month or two of her feeling comfortable on it. And then due to that difference in that LH to FSH ratio, I added an inositol. And so for her, we started at about 1,000 milligrams, and same thing, we went up to 2,000. 2,000 is about the therapeutic dosage that I see helpful. And then we added in additional pumpkin seed oil on top of her taking pumpkin seeds daily. And then pygeum is one that we didn't add in, but I wanted to talk about is often researched in the literature to be helpful for reducing DHT too. So there are some combo products that include saw palmetto, pumpkin seed oil, and pygeum in there. And that's a general dosage out there for daily dosing. In terms of lifestyle changes with her, so she was someone that loved high intensity training. She loved strength training. Yeah, like I mentioned, she was such a go-getter. And so we actually talked about, let's reduce the HIIT training. Let's do more low intensity. Let's do Pilates, yoga, walking, just because it was seemingly like her body was, because it was favoring more of the androgenic pathway. I said, let's try to just kind of focus on reducing just kind of her overall, cortisol in her body to see if that will help with lowering this pathway too. And then skincare, the theme is pumpkin seeds, and we're in pumpkin season. So we went ahead and added on some pumpkin seed topically, as well as did some topical green tea compresses. So she had cystic acne, but it wasn't too deep or too inflamed. But with the topical green tea, that also helps to reduce DHT locally on the skin as well. So what we do is we would have her steep some green tea, and then we put a cloth in the green tea, organic of course, and then put the compress on her face after she washed it twice a day. And then at bedtime, we found a pumpkin seed oil topically that she could use as well. And that was kind of like a moisturizer for her. And then Dr. Savani, I'm going to leave the medications for you to talk about and just kind of give your expertise on how you'd approach this case as well.
Well, I think a lot of us are looking for what are the other options here. The other thing when you're looking at pumpkin seed oil, you can get them from Mountain Rose Herbs. They make a really nice, high quality, validated pumpkin seed oil. It's not that expensive. I'll put it on in the evening after retinoid. Speaking of medications, I will utilize a retinoid. And I've now started to utilize, if you can do clascoterone topically, that's fine. But I will work at a compounding pharmacy. And now what they're doing is they're doing spironolactone topical. And I'll use that 5%. And they will mask the smell because it doesn't smell that great. They'll mask it with tea tree oil. And tea tree oil has independently been shown head to head against benzoyl peroxide to be useful, especially when it's diluted instead of just going to straight benzoyl peroxide. I did want to say another thing when it comes to these hormones. One of the other things that I like to also add on, and this was such a nice summary of how you've approached this. And I think this is the kind of detail that a lot of us want to get because we want to understand, hey, what are we looking at? And before I jump into that, though, there was a nice question that came through from Jackie. She said, so the test doesn't label DHT?
So specifically what's unique is I've actually seen with the female hormone testing, it doesn't label DHT, but when males do it, they do. But they give you an entire interpretation guide as well, and will basically go ahead and tell you that that's essentially DHT.
So there you go. That hopefully clarifies that. The other thing that I like to make sure that it's kind of nice from the testing that we do here is that you'll get a sense of the 4-point cortisol and their cortisol spikes, which I know that Ruby's going to touch on in some future things here. But the other part of it is that insulin. I think it's really important to look at fasting insulin, fasting glucose, because if your insulin is riding high, one of the ways that myoinositol works, and I usually like if they can tolerate 2,000 milligrams, I like that because it potentiates glucose to get uptake into the organs. And, our big ones are the liver and the muscle. That's where glucose gets taken up a lot. And so making sure you have active muscles, whether it's low intensity, but still making sure you're working those muscles out, I think that's really important. And then the other one is just looking at fasting insulin in general. How hard is your body pumping out insulin to get that glucose out of the circulation and into where it needs to go? And the harder it works, guess what that means? It also means it's harder to do lipolysis. So you're going to hang on to your weight a little bit more because your insulin's higher. And also it can trigger release of hormones from the thecal cells, which can also be another trigger to things like hair thinning and whatnot. So when you're looking at hormone testing, don't forget about insulin and don't forget about glucose. Doing that fasting glucose insulin can tell you a lot about liver health and also just like in terms of fatty liver, and also just seeing where are they with their insulin glucose homeostasis. So it's not all hemoglobin A1C. Okay, so we've got to keep moving because we've got two more cases and some other things to talk about. So here's, I guess, some of the recommendations, right, that you've got, Ruby. Maybe walk us through what you're addressing in this particular slide.
Yep. So I'll go through. So these are the most commonly used products I use for my higher androgen female acne patients. So PCOPX, I love because it has more progesterone support. So it targets your androgens with the saw palmetto, the inositol in there. But then there's also Vitex. So it's a great way of balancing kind of that DHT to progesterone kind of mismatch that I was talking about. Saw palmetto plus has the added pygeum as well as nettles in there. So if we're just focusing on that, reducing that 5-alpha reductase pathway, this is a great option. And then Testo Quench has been my go-to for many years now. I've noticed that it's on back order a lot. So I think one of the questions is, where do you source a lot of these supplements? And so generally I usually go to FullScript to place most of my product recommendations for patients. So Testo Quench, I love. I've seen it work wonders with patients. And so generally I start at the therapeutic dosages, and then sometimes I'll double it depending on their value. So I believe Testo Quench is 3 caps QD, so 3 caps daily. And sometimes for this patient specifically, I'd do 3 caps BID. And then same thing with the saw palmetto plus. You just kind of want to see, they all have different values of saw palmetto versus pygeum and different nutrients in there. So depending on the constellation of symptoms and values, these are some great options.
All right, so we've got another case, and this one, slight different variation, 31-year-old female. Again, super common, unfortunately. And we've got the same sort of hormonal acne, gets breast tenderness, PMS symptoms, concern of heavy menstrual bleeding. I really like this case because this is a little differentiated from the previous case. You're not necessarily thinking PCOS here. This is a little bit more of, gosh, hormonal cycling. Could there be something going on here with a different sort of hormone balance or imbalance? So again, one of your cases. So let's walk through this one as well.
Perfect. So for this one, I'm going to just start off in terms of my clinical thinking. So the first thing I think about when I hear breast tenderness, PMS, heavy menstrual bleeding, hormonal acne, primarily around the chin and jawline, is having just generally more estrogen. And more estrogen can come from having and actually producing higher amounts of estrogen, or producing, less amounts of progesterone. And so, same thing, we started at day 1 of her menstrual cycle. We looked at the same labs again. So this time it revealed a normal free and total DHT. Her free and total testosterone are looking healthy and within normal limits. Her FSH to LH ratio is closer to that 1-to-1 ideal ratio. LH a little bit higher, but also indicating that she had some ovulation there. Her cortisol is looking, healthy. Estradiol doesn't look alarming in this situation, and her progesterone looks subpar at that 0.3. So I'm already thinking, okay, she seems like she's having a little bit of a lower progesterone or progesterone insufficiency here, but I don't exactly know what's happening with her estrogen or what's going on with her metabolites.
And what's really nice is you can see the estradiol progesterone ratio is quite different here. And so I think looking at these ratios are important. I love that you're emphasizing this. Everything isn't just a line item. It's like the line item in the ecosystem of the hormones. All right, so the magic begins again.
All right, so this one's a little bit harder to read, so I will start breaking it down. So what was unique in this situation as well, she had a lot of different, a constellation of a lot of different symptoms here. So once again, I'll start with her androgens on the left here. Same thing, her DHEA sulfate is looking healthy and normal. Her testosterone is looking a little bit lower on the normal range. But her DHT, she's producing more of the 5 beta pathway when we're looking down at DHT. So she has more of a 5 beta preference rather than 5 alpha preference. So she might not be presenting with the same types of symptoms that the first case had, with that hirsutism, that widening of the part line. But it could be contributing to some of her cystic acne as well. But I'm going to emphasize more with her the progesterone as we go over to the right. So is once again, not in an ideal range. It's not even within a normal range here. And it does line up with her lower progesterone that we saw through serum lab work. And then if we go down to her estrogen, so let's look at the estrogens pathway here. So we can see her E1, E2, and E3 significantly elevated. So she is, topping out of the range between all of her estrogen. But what was unique is, when we did through serum lab testing, it was nowhere even close to being at the top of the normal range there. So now I wanted to break down her metabolites a little bit more. So to kind of understand, so if you see that green arrow, it says more of that protective pathway. So like I mentioned, that's the good estrogen, the healthy estrogen. And then we have the 4-OHE1, and then we have the 16-OHE1. So generally from what I've seen is the 4-OHE1 can contribute and 16-OH can contribute to a lot of different premenstrual symptoms. So that being said, the breast tenderness, the mood changes, the migraines right before the cycle, and we look at her pie chart of her, different estrogen ratios. And so she is technically within range of her healthy 2OH, the good estrogen, but she is also, considerably within ranges of, each of the estrogens to one another. So even though comparatively her ratios of estrogens are within a good range, she's just way overproducing them. So that is what I wanted to talk more about, is her estrogen is definitely elevated here. Oh, here we go. And we went ahead and just focused on it a little bit more. And then I want to talk about the just kind of methylation pathway and that 2-methoxy-E1. So methylation is quite a buzzy word nowadays. And so it basically tells us, are we able to kind of, break down a lot of different B vitamins? Are we able to methylate them? Are our tissues able to process them as well here? So what we can see with her 2-methoxy-E1 is she has a lower methylation activity. And so when some individuals have a lower methylation activity, they might just have a harder time processing certain nutrients or metabolizing certain estrogens out of the body too. So this is a good indication that we have to add in, more support for metabolizing and excreting estrogen out of the body, as well as supporting her in reducing the amount of estrogen that she's also, producing. Okay, should I take away the sample treatment plan I did with her?
Yep, I think I think the takeaway here is that this is a different kind of hormonal imbalance. And you can
Mhm.
see, I just want to kind of tag along to this because this is really interesting. Two, acne presentations, but pretty different. Here, spironolactone may or may not work as effectively. And I think that that's the big takeaway, is that anytime you see hormonal acne, our medications may be limited. And when you go into the supplement space, you have a lot more versatility. You'll see myo-inositol doesn't show up in here because we're not thinking about priming that that the glucose has to get in, because you have glucose levels that are higher. Again, I think checking fasting insulin, fasting glucose would be helpful. But let me turn it back to you, just to talk us through your thought process here. And we look like we have some follow-up questions too once you get through this.
Sure. So I'll start with nutrition. Once again, I always start with the foundations, and I try to understand also, when I see higher estrogen, I think about, what are people putting on their skin? What are they breathing? The first thing I go through is just reducing xenoestrogens. So that can mean reducing fragrances. A lot of these individuals are putting, perfume on, scented lotions, just a lot of scented products. They're potentially eating in a lot of plastic. So they're getting to-go food, or, they're eating in plastic containers, and just a lot of different, just kind of various bleaches. Let's say, like, even in a lot of women's menstrual products, such as tampons and pads, they're bleached. All of these are considered xenoestrogens too. So I start with the foundation, starting with reducing the xenoestrogen exposure in the environment. Also considering, air purifier, water filters if we need to go down that route. But then going back to nutrition, so, some of the best ways to support estrogen metabolism and detoxification is just talking about diet. So once again, 2 tablespoons of ground flax seeds daily. I forgot to mention the word ground in this slide, but it's very, very important to add in the ground flax seeds for the essential oils that come out of the flax seeds. And that will help with just reducing just overall estrogen. And then cruciferous vegetables and broccoli sprouts are some of the best ways to help with metabolizing, supporting phase 1 and phase 2 liver detoxification. So a big key component of a plan when it comes to estrogen detoxification is supporting the liver. So we talk about foods for the liver, we'll talk about liver supportive agents through supplementation. There's a variety of different ones out there. I personally really love, milk thistle. I love curcumin if there's more of like an inflammatory type of acne. Burdock root is great. Liposomal glutathione is almost essential in most of my treatment plans to help with detoxification because it's a master antioxidant. That's usually where I start. And then another thing that I didn't add in is castor oil packs topically to the liver too. So, doing that 20 to 30 minutes a couple times a week is one of the best ways to help with just supporting that kind of drainage process as well. But then kind of phase one is supporting the liver, optimizing that to help with detoxification. And then phase two is just, really adding in more estrogen supportive and detoxification type of agents. So DIM is my go-to. That is the first place that I start. DIM dosages can vary. Some people are very responsive to DIM. They can start at 100 milligrams a day. Usually I tend to go up to 200 because in those higher estrogen kind of, patients, they tend to need a little bit more initially to help with kind of binding that estrogen. What I've noticed too, so calcium D-glucarate, if people have more of this is a great one when they're having more concerns with and want more support with phase one and phase two detoxification. So this is great if they're also kind of having a backup of estrogen in the stool. The way I confirm this is actually through gut microbiome testing, which is a whole other option. But if I see that they're having elevated levels, that's a great one that I add in to help with binding the estrogen from stool especially. And then indole 3 carbinol. So some people I've noticed are more responsive to calcium D-glucarate, and some people are more responsive to indole 3 carbinol. A lot of DIM supplements have one or the other with them. So usually they tend to start with the calcium D-glucarate, but if they're not as responsive to it, then we can add in the indole 3 carbinol. And then Vitex is to support that progesterone. So like I mentioned earlier, so a lot of individuals have higher amounts of estrogen, and sometimes it is because it's a progesterone deficiency. So by adding in progesterone, especially during that luteal phase, can help with boosting, progesterone amounts and help with reducing the estrogen dominant like symptoms. And then, topically is another great place to add on. A lot of women with more of the estrogen-based acne tend to have more of an inflammatory acne. So I like to add in aloe, ceramides, beta-glucan, hyaluronic acid, things to calm and soothe the skin. Salicylic acid, if, potentially if they're having, more sebum production, but that tends to actually be more so with the higher androgens.
And on that note, actually, there's a question that came in, which I'm sure is going to be on a lot of people's minds, which is that, when you go through residency, you're actually kind of taught that estrogens are better for acne and progesterones, like IUDs, are more problematic. And one of the questions is, can you clarify this? I can start, and then I think maybe Ruby, you can take this afterwards. But, the first point is that this is, of course, always in a balanced ratio kind of range. But you can always run out of these ranges, and estrogen dominant acne tends to be in a different part of the ovulatory cycle than progesterone dominant acne. And you don't have as much sebum production, but unfortunately, you can still have a lot of inflammation. And so it is true, generally speaking, that especially when you're trying to look at the balance between progesterone and estrogen, you need the estrogens to keep the progesterone in some level of balance. However, when you go out of balance, as you can see, like things are outside of the typical ranges, then you unfortunately run into other issues, including the other symptoms that she had. But Ruby, you have a perspective on this as well?
Yeah, to just elaborate a little bit more. So in a lot more of the estrogen dominant type of acne, they tend to have more of that luteal phase breakout. So they're breaking out, generally 1 to 2 weeks prior to their menstrual cycle. And so there can be, there's some theories where either going on a hormonal IUD that's the progestin based or progestin only pill can sometimes remedy that. And there's some women who, really do suffer from really heavy menstrual bleeding, a lot of clotting, and they're quite debilitated and have noticed at least a reduction in a lot of those symptoms when going on these medications, if that were the concern. Once again, it's not something that I generally recommend in practice, but I just know it's an option, and many providers do offer that. I can say I wouldn't indicate an oral contraceptive pill in more of an estrogen dominant individual, just because it can be feeding them synthetic estrogen when they're already producing a significant amount of estrogen, which can potentially perpetuate the process too. So hence why IUDs, because they are progestin only based, if you go down that route, can potentially be helpful in some.
All right. Well, in the interest of looking at time, let's quickly run through these recommendations. And I think the next case will be really interesting because it's also another unique approach.
Sure. So these are some products that I use. So DIM Detox is one of the best ones if you want to support liver detoxification at the same time as supporting estrogen. So that has a lot of liver supportive herbs as well as DIM in there too. CDG estrogen has that calcium D-glucarate as well as the DIM in there. So if you're just targeting that elevated estrogen, this is a higher potency of it. And then FemGuard Balance is a really wonderful one. I'd say it's a great one that has it's a less of a therapeutic dosage in terms of that DIM and that calcium D-glucarate, but it has a lot more of just kind of general hormone balancing, anti-inflammatory in there. So let's say if someone's sensitive, or I have a lot of women who are coming off oral birth control, they want to start balancing their hormones, I'll start them on the FemGuard Balance. And then
All right.
I was
Go
just going to
ahead.
say, I saw one of the questions that people were asking about estimated timeframes to start to see
Yes.
changes when it comes to implementing these. What I will say with the first case with the androgens, it takes at minimum 6 months to start to lower androgens when using these products naturally, but estrogen can start to change within 3 months. So I've seen that. I've often done repeat Dutch testing in that time frame, and I'd say as soon as 3 months, but I usually always give my patients the time frame of 3 to 6 months is usually when they start to see changes.
And since we're on the topic of hormones, can you discuss why you okay, so one of the questions here is, can you discuss why you test serum hormones at day 19 to 21 instead of 2 to 7 of the menstrual cycle?
So it just happened to fall in this pattern when I was testing their hormones. So generally, I agree. It's best to test estrogen at day 3 of the cycle. And then day 19 to 21, we can understand progesterone a little bit more and see the LH to FSH ratio. So I look at, kind of how many more hormones can we get for the bang for our buck? If we're already going to be doing Dutch testing anyways, I'm going to choose the luteal phase hormones. But generally, if you aren't testing hormones through urine, it's recommended to test estrogen at day 3, and then testing, at least your progesterone and LH and FSH between days 19 to 22 of the menstrual cycle. You can test your testosterone at any day of the menstrual cycle, just generally before 10 a.m. Same thing with cortisol, and then estradiol and progesterone are a little bit more time locked.
All right, let's go to case example 3. I know there's another question, but we'll come back to that one.
Sure.
So, and I think this one is a little bit different from the other ones, right? Again, we've got the cystic acne, a bit of anxiety, a little bit of hair loss, heart palpitations, regular menstrual cycle. You draw the serum labs here. I know this is your patient, but the first thing that's striking to me is everything is actually within the normal range in this particular case. You don't really see anything falling on any of the extremes, except we have cortisol, which may be related to her anxiety, maybe the heart palpitations. So now you're starting to get a different sense, and you can see the LH is actually lower than the FSH in this particular case. So when we look at the Dutch testing, a little bit different flavor. So Ruby, take us through this particular case and what got you to think in this realm.
So I'm just going to start with the hormone testing summary on the right. So as we see here, this is the first page of the Dutch test, and it tells us a brief overview of her hormones. So, her estrogen is it's in a good normal range. Her progesterone is actually, above estrogen. So usually I look at a 1-to-1 ratio, same thing on the hormone testing of estrogen to estradiol to progesterone. And then her testosterone is, same thing in a normal healthy range. But I look down at her total DHEA, and that's, trending upwards. And then I look at her daily free cortisol pattern. So what's unique is she's following the normal cortisol trend, but if we look at her 24-hour free cortisol, that's definitely topping out on the high end of normal. And then we look at the cortisol metabolism right next to it, and that's it's within normal range, but it's lower than what I'd like it to be. So we now look at the left here. So I look at the daily free cortisol pattern, and so she has a normal healthy waking cortisol. It spikes up. She's kind of hitting the upper high range limit of cortisol. And then her afternoon cortisol is above the normal range. And then her nighttime cortisol is staying pretty high. I look at the cortisone metabolism. So we look at cortisone. So how well is the body metabolizing the cortisol, and when is it metabolizing it too? So her body's trying to metabolize it and keep up with it throughout the day. But what I think is unique here is she is just overproducing a lot of cortisol in this instance. Hence, that could be leading to the heart palpitations. It could be leading to the hair loss. And cortisol has a direct effect on supporting, the HPA axis and pushing many of our hormones too. So even though her hormones do look healthy, this is more of a case of, having elevated cortisol.
Great. And I think this speaks to the fact that even if you see like this, and no, obviously just to orient, this is a 4-point cortisol, but you still have that daily rise in cortisol. And so if you're running along the high range, maybe you haven't petered out the adrenal glands because you're young enough that you're able to, or like robust enough that you're able to push it out, but you're still like, you're driving the car very fast. The engine hasn't started to fail, but you've definitely got the accelerator on. I think
Oh,
that's the point here.
absolutely. You're revving the engine on that one.
So, all right. So you've got, this is a little bit different. So now you're looking at, and this is what is meant by adrenal support. It's like, okay, how do we get the stress down? Obviously, this is going to be multifaceted, holistic. And before Ruby jumps into things, I think first and foremost, you see that lifestyle changes are, unfortunately, we live in a society that really drives the car at a very fast accelerative pace. And so bringing in things that are going to be restorative, and when it comes to yoga, there are many different kinds of yoga. They don't all have to be hot yoga. I just want to make that point. If it works for you, great. But there are other kinds of yoga that can be meditative, and it can be a little bit slower. So for any of you that are thinking, oh gosh, I don't like hot yoga, or maybe a patient might not, just realize yoga doesn't have to be always Bikram yoga or something along those lines. Okay, let's turn it back to you, Ruby, and give us a sense of how did you approach this one? And clearly, you've got some different approaches here compared to the past two cases.
So I also want to mention with cortisol, cortisol can trigger a lot of, producing more insulin, blood sugar dysregulation. So this is a really great case and a really great example of also further evaluating insulin, blood sugar,
Yep.
looking at their lipid levels too, and just understanding their whole picture, as well as understanding, are they inflamed? With this patient, I'm just gonna focus on the cortisol, but we ended up doing gut microbiome testing and found out she had a lot of inflammation generally. So a lot of times with my higher cortisol patients, I tend to also evaluate other things down the line. I know we're just focusing on hormones here, but one thing I just wanted to start with, same thing, basics. Like she was someone that was working really hard, getting up really early in the morning, waking up at 4 a.m., getting her HIIT training in to be at work by 8 a.m. She wasn't sleeping much. She was having insomnia. So I just said, okay, let's just pump the brakes. Let's do more restorative activities. Let's slow down. Let's walk. Let's maybe switch from your really early morning workouts to a time where it's more restorative, like a mid-afternoon walk or an evening walk. Let's add in some meditation in the morning so she's not spiking that cortisol. My favorite thing to do, and a lot of my patients hate me for it, is I take away their coffee. That's the first thing I do because they are living on coffee.
Blasphemy.
It's a classic case of they are fueled by coffee until noon. And so it's glass after glass or latte after latte, and then they eat lunch and then they crash in the afternoon, and then they're exhausted in the late afternoon, and then they're tired but wired at night. I see this so often. And so I always start with encouraging people to switch to matcha because it still gives them a little bit of caffeine, but it has that L-theanine for that calming effect too. And then another thing that I switch up is I encourage them to have breakfast within 1 to 2 hours of waking. And so usually these people are not hungry in the morning. And that's a sign, that's a telltale sign. If you're not hungry within 1 to 2 hours of waking, there is some cortisol dysregulation. We should be, hungry in the morning. So I'm trying to encourage them to put their body into rest and digest by starting with more restorative activities in the morning and getting them into eating some protein, especially for breakfast, and incorporating regular meal times because the body likes to know when it's going to be eating, so it's not in a state of starvation. And then just to encourage a lot of salt. The adrenal glands, really love salt, but also just be mindful of if there's any hypertension involved. And then a lot of vitamin C rich foods to really nourish the adrenal glands. They love fruits, they love antioxidants, they love vitamin C. And then went into some more supplements. So when there's high cortisol, I like to use, cortisol lowering herbs. And so holy basil is my go-to for especially that daytime cortisol. And then ashwagandha, I love to include in the day and the evening as well. People really love to have more of that calming effect with it. Milky oats is a really nutritive herb that helps with calming the nervous system as well too. And then rhodiola. So I use that for those. I'm going to caution this one. So for those who have anxiety, caution with the amount of the dosage. And I wouldn't recommend it past noon because it can lead to just, more concerns with falling asleep at night. But if some people want it to help focus, I would recommend adding it in. And I always love to tell people the story about rhodiola. And if we have a moment, I'll just share that it's grown in like the Peruvian Andes. So it's grown at these really extreme elevations and extreme temperatures. And so when it's harvested, it's a really resilient plant. And so that's what I love to tell people is it will help you to just kind of like rebuild your adrenals to kind of incorporate to help with supporting stamina too, especially if those are getting that afternoon fatigue there. And then just skincare, I mentioned. So it was that stubborn, just kind of cystic acne. So I wanted to just do more barrier support, inflammatory support. So adding in some peptides and ceramides, some glycolic and lactic acid because she had a lot of texture concerns. And so that can help with just reducing the texture. But this is a good case of, also just educating. This is just educating them, and lifestyle factors play the biggest role in these patients.
So you can see from these three cases that quite different, but end result is you have someone that's struggling with acne, but the way we approach it is obviously there's some ways that you can customize, but I appreciate, Ruby, that you've kind of put this into perspective on how you might approach it. And of course, in a given patient, you might mix and match some of these that go back and forth if you're trying to address certain things.
Absolutely.
So, yeah, why don't you take us to some of the recommendations and, why you might choose this in this particular case?
Sure. So needed stress support. It has that holy basil in there. It has that milky oats in there. A lot of the cortisol lowering. But I use this one if those individuals also have a little bit of like hormonal irregularities because there is shatavari in that one too. And so if someone's having, let's say, either they're too frequent menses, too delayed menses because of that cortisol, I really love the needed stress support. Oftentimes it is either back ordered or out of stock. So my other two that I go to are HPA Adapt and Daytime HPA. I've been leaning more towards the Daytime HPA because there's mainly just nervines in there. So just, adrenal supportive nutrients. HPA Adapt does have some maca in it. So I will caution some individuals are sensitive to some maca. So that being said, if a woman's going through perimenopause and is having higher amounts of stress due to just, life, that's a good one for them. Or if they know they're having just generally lower estrogen. But I'd say daytime HPA is a good balance blend for most of my patients.
Fantastic. I love that we've gone through a few of your favorites and like different case presentations. One of the questions that came up, and I do want to also give us a little overview of the Integrative Derm Certificate Program, but before we get there, what would low cortisol indicate is one of the questions that came in. Ruby, you want to take that one?
So in terms of presentation in symptoms,
I'm not
uh,
sure. They don't really state, but just because we were talking about how the cortisol was high,
got it.
so what would a lower cortisol indicate, I think is the question.
So lower cortisol, if we looked at their Dutch test, the patients that present with low cortisol, they're fatigued all the time. They wake up, they maybe have energy for an hour, but then it feels like they got hit by a train. They have brain fog. They're struggling to get through the day. And then by the time night comes around, they maybe have a little bit of energy to get things done. But it's usually my patients that are like, I don't know what happened, but I'm just exhausted all the time. And I would actually have different recommendations for adrenal support for them. So you want to give them things that nourish the adrenal glands. And so this is a time that I would actually focus more on the rhodiola. I would actually do erythro. I would do ginseng. So more adrenal kind of reviving. And I would really, really encourage them to rest because their body needs a lot of it at that time too.
Awesome. And the other thing is if your cortisol is really low, you've kind of overloaded the system. So
Yeah.
you will get a lot of people that now instead of go, they're now getting into the burnout scenario. So that's unfortunate. Okay, so just as an overview, first of all, thank you so much, Ruby, for such an awesome set of cases. I think that it really puts Dutch testing into perspective. Obviously, this is not comprehensive, but in many ways, it gives you a flavor of how valuable Dutch testing can be, in addition to other testing that you might do. And don't forget the fasting insulin, fasting glucose. I think that really should be part of your hormone assessments. And that brings us to the Integrative Dermatology Certificate Program. For those of you that are in it, fantastic. Those of you that are not in it, just realize that this is a program that's a 9-month program. You get all your CMEs, and it's online paced didactic lectures, and we have weekly roundtables, and we have these awesome intensives. And so it really gives you a chance to meet each other. I think a lot of people would agree that that's really fun. There's Apple, Peter, and myself that really put this on, but we have a lot of lectures. You'll probably hear from Ruby as part of this, especially when we get into the functional testing. And so you'll get a chance to really dip into the different aspects of medicine. And with functional medicine, the challenge has always been evidence, but I think now that's starting to shift as we're bringing more cases forward, some scenarios forward, and there's more research that's now emerging on how this all works. And the point here is that, and I think you've gotten a flavor of this, is that when we're thinking about integrative dermatology, you're not just focusing on the quote alternatives, which I don't know if people use alternative medicine anymore nowadays. I think they've really migrated to integrative medicine, just noticing that all parts of medicine can have evidence. We might say conventional, but one thing that's exceptionally sad with conventional medicine is we never talk about nutrition. And so now that's on the table as well, pun intended, by the way. And so this was designed by dermatologists for dermatologists, but the idea is that it's not just dermatologists that are going to be collaborating to bring you all of this content. As you can tell from today, we're really getting people that are experts in each of their different fields. But the idea is that we also understand the unique challenges that people have within dermatology. And there's a lot of different topics that you probably didn't learn about, but would be really nice because you might change your life too as part of it. And so along with this comes access to the LearnSkin community platform. This is really awesome because you get access to all the alumni, premium members, faculty, and also many of the programs that are out there, whether they're free or even the premium content is, I think, really nice. And you also get a chance to see the Integrative Derm symposium. So, but before we get there, the alumni feedback has been really, I would say, humbling in many ways. There were people that said they were on the edge of burnout and said, okay, I've got a renewed energy and passion, and things that really make you rediscover what it means to be a practicing physician and practicing dermatologist. So that's been really exciting. We've got, people just talking about how the learning has really changed. And I will tell you, all of us that are also teaching in the program, we continue to learn every single time too. And so there's so much emerging on a year-to-year basis. And of course, you have these awesome pre-IDCP conferences and intensive workshops where you get a chance to really delve into getting to know each other. And not only that, getting to see things that are more practical in a sense. And then, of course, we have a lot of fun. And who's more fun than us when we've got a board to take photos, or if we're playing Jeopardy on this previous slide, you can see here. So there's all these fun things that we do. And so, we do want to make sure that you can also join us, and you get this as part of your registration if you join the IDCP, the Integrative Derm Symposium. We are going to be headed to Arizona. This is a beautiful resort. Awesome time when we were there last time, but now we're going to the Westin, and it's in Tucson. And so we'll be, again, bridging traditional wisdom with the latest in evidence base. And the applications are due by April 21st. There are some discounts if you're an early bird. So we're hoping that you join and take advantage of this. And so I think the main points here are that the IDCP really offers you an insight into what it means to be integrative, and we try to really bring that in a practical way. And as you can tell, from today, you got a sense of how Dutch testing can work, how you evaluate these hormones, what about cortisol testing, and that serum lab testing, while useful, isn't necessarily always the full picture, and that getting those urine testing results is also important too. So we do have, I think there was one more question, but Ruby, you ended up answering that, didn't you? Just from typing? Okay, perfect. Well, with that said, I just want to thank all of you for joining us, because I know it's on a Tuesday evening, probably after clinic. I know that all of you are looking forward, cozied up on your pillow for this Learn Skin webinar, and now you feel Dutch test ready. But regardless, we appreciate the time that you spent with us, and please do join us. If you're already part of our programs, we love it. Continue to join us. And if you're thinking about it, do it. Don't wait. It's going to be the best decision that you've made this year, hopefully, and in the coming years as well. And then Ruby, as always, Ruby is so fantastic. We work together. We do a lot of research together. So we're like knee deep in evidence, but there's the art of medicine, and clearly you're an artiste. So we appreciate you and your expertise today.
Thank you,
All
Dr.
right,
Smith.
everybody. Thank you all.